Good morning and welcome to today's webcast, Risk and Capitation During a Pandemic. We will be saving time at the end of the webcast to answer your questions. To ask our presenters a question, please type in the Q&A window and click Submit. If we don't have time to answer your question, we will do our best to follow up with you after the webcast. In addition to today's presentation, Moss Adams has many resources to help you navigate COVID-19. You can find links to these resources in the slide deck and handouts widget to the left of the slide view. Finally, the material appearing in this presentation is for informational purposes only and should not be construed as advice of any kind, including without limitation, legal, accounting, or investment advice. And with that, I will turn it over to our moderator today, Karl Rebay, to get us started.
Thanks, Emily, very much. Good morning, everybody. Thanks for taking time out of your busy schedules to join us. I think we've got a really great discussion in store for everyone. I want to point out right away before we get rolling that we have Melanie Matthews on the line. She's the Chief Executive Officer for Physicians of Southwest Washington. I'll ask her to do a little more of an intro, but unfortunately we couldn't get video working for her this morning, so she's on audio only. But please know that Melanie is part of our crew. We're joined today by three people that I've gotten to know very well over the years. Super grateful for you all joining us today. Looking forward to a real good discussion about a business model that you know, maybe on the West Coast we know pretty well. Across the country, it seems to be growing rapidly, and there's a lot of interest in it. Typically, there are a lot of nerves around it as well for those who aren't very well versed in provider risk. But we're going to get into a little bit about that today and how folks are faring in light of COVID-19 and the ensuing economic situation. But I'd like to introduce our group. I mentioned Melanie, and we've got Don Crane from AbbG and Ray Chicoine from Monarch Healthcare. Again, all three folks I've gotten to know very well. If you wouldn't mind, I'll start with Don and ask you guys just to maybe say a few words about yourselves and about your company and perhaps a little bit about what your mission is.
So thank you, Karl. I'll start. So I'm Don Crane. I'm the president and CEO of America's Physician Groups, APG as we're now known. So we're 345 physician organizations across, I think, 44 states at last count, representing really the value movement. So we have members that have been in capitation for a couple decades. The other end of the spectrum, we have newcomers that are in Medicare only ACOs, and we have groups everywhere in between as well. So, you know, we're devoted to the value movement generally, and I think it's fair to say all of us see capitation or something very budget-based like it as being the destination. So we're real interested in the title of this webinar relating to the pandemic and how capitation and risk models are faring. And so I look forward to the questions, and thank you for having me.
Absolutely. Ray, how about you? Why don't you go next, please?
Sure. Good morning. Ray Chicoine, president of Monarch Healthcare. Monarch is an IPA model that was formed in 1994 in Orange County, California. Fully capitated model. Vast majority of our revenue is prepaid for value-based care. Largest IPA in the market, over 800 physicians, 800 primary care physicians, 1,500 specialists. We affiliated with Optum in 2011. We created a employed model medical group about 5 years ago, and it's become an increasing part of our delivery system. And now we employ over 200 providers, primary care and specialists. We do participate with all health plans and all products. So commercial business, Medi-Cal, Medicaid program in California, and our Medicare Advantage patient population. And again, as part of the Optum family, we have a large, diverse, integrated business in California.
Great, thanks. And Melanie?
Sure, thank you, Karl. Good morning, everyone. Physicians of Southwest Washington is an IPA that was formed in 1995, so around the same time as Monarch. And the organization is really built on taking capitated full risk, and so the whole sort of soup to nuts around delegated activities, and managing Medicare Advantage was sort of the sweet spot. And so through the course of MACRA and many of the value-based movement in the state of Washington, we expanded our business model to really focus on the core legacy business, Medicare Advantage, and then take on new alternative payment models. So we convene next generation ACO, and then we do bundle payment care initiative, as well as MSSP Track 1 Plus. And about 2.5 years ago, a vertically integrated system and regional player called Multicare Health Systems invested minority interest in PSW. And so part of our responsibilities is to support the value-based work in a larger integrated $3 billion healthcare system. So we have about 100,000 lives at risk and do a little of everything from commercial and federal government models to the Medicare Advantage business. And we operate right now in about 14 states doing some of the management service organization work. Thank you for having me, Karl.
Oh, absolutely. And thanks again for joining us, everyone. Yeah, Melanie, I just, I can't help but think about the role that you all have taken at PSW with respect to what you're helping Multicare achieve in the value-based world, and it really is remarkable. I know Dawn and Melanie, you've both been to our conference in the past and have moderated and have spoken on this topic, and so it's fascinating to see how, frankly, rapidly in some areas of the country things are changing. I know we'll get into that a little bit. How folks are sort of thinking and feeling about this model. Before we jump in, we're going to do a couple things. One, I want to show, I'd like to just kind of give everybody a little bit of an overview about what we're going to talk about today, and then we'll open up with a poll. But you can see here, what we want to cover with our team here. We really want to understand what it feels like during this health crisis during the pandemic to be a risk-bearing organization. Because I mentioned earlier, there are a lot of nerves around getting into things like capitation and ACOs and MSSP and these business models that have downside financial risk. So we want to hear from folks who are running organizations and involved in organizations that live in this world, how they're structured. Again, you see the third bullet, to pivot and leverage. One of the things that we are seeing, which I'm going to be very happy to hear about in this discussion, some of the practical things that folks are doing, that organizations are doing, and capabilities that they have. And then, really how the payment structure has been a part of their ability to take care of folks and continue on the mission of population health. And then hopefully we'll have some time at the end for Q&A. Please feel free to log questions. If we can get to them as part of the discussion, we will do that. If not, we will definitely follow up with answers to anything that anyone asks via email and probably on our site. But we'll make sure that we address what we hear from you all. So this first poll, and I'll leave this up for some little bit of time here. Do you believe risk-bearing organizations are faring better or worse than traditional fee-for-service organizations so far throughout COVID-19 pandemic in the ensuing economic situation? I'll just leave this open for a little bit of time here as folks log in. The ability to, deal with a budget-based model is something that we've been thinking about. The ability to, continue to provide support for your network, physicians and physician groups. These are topics we're going to talk about today, but we thought we would do a little bit of a gauging as to what folks are thinking at the beginning of our discussion. So I think that's probably enough time, right, Emily?
Yep.
All right. So not overly surprising, but again, we're not quite sure exactly who all is in the audience today, and this helps us sort of gauge our discussion. Looks like the vast majority of folks do believe that the risk-bearing organizations are in a better position to deal with a situation like this, and we're going to hear a lot about that today. So let's just get right into it. So one of the things that it would be great to hear about at the outset of this is what you all did and what you're doing from an operational and clinical standpoint. So what are the things that you're actually doing and actually did when this thing hit? You know, when the pandemic really started spreading, we had governors, you know, closing off elective procedures and all of the craziness that ensued. Melanie, would you mind speaking first to that?
Sure. You know, as a risk-bearing entity, one of the interesting things I felt like being on both the delivery system side with my Multicare engagement as well as the IPA side was how different the resources were and the focus. So I think about on the healthcare delivery system side, the organization was preparing for, rightfully so, for surge and really the clinical manifestation of COVID and how to respond for staffing, equipment, you know, surge rooms, converting, those sort of things. Where on the IPA side, we were really taking a very aggressive look of how we could take all of the data related to our patients from a clinical and claims-based process and risk stratify those that were more at risk for COVID exposure or, you know, chronic comorbidities that may make them more at risk to get very sick. And so the IPA side, we were able to help deliver things like meds and food and connections for telehealth. And I felt like through the process, we were really, you know, doing 6 months worth of work in like 10 days. It just seemed like overdrive to help accommodate the needs of the community. And then secondly, from an IPA standpoint, we have a lot of Marcus Wellesby's in our market. They really had no ability to up their supply chain. So one of the things we ended up doing as a series of activities was setting up supply chains for, you know, masks and gowns and all sorts of equipment that the provider community needed. So that was sort of our approach, and it was very different depending on which system that we were supporting in that work. And
you know, what you mentioned there towards the end, the ability to support your network with things like supply chain, you know, that's so the IPA model is physician groups and physicians brought together into the IPA via a contractual mechanism. And so what you're saying is that by virtue of those relationships, you were able to provide support to your network physicians. And so you talk about supply chain. I mean, these are very practical issues that physician organizations and other healthcare organizations had at the outset when supplies ran dry, when funding ran dry. And so you're saying you were able to continue to support these folks in their endeavors to take care of your members.
Yes, that's exactly right. And I think that was the approach was, you know, when you have a system, you have a supply chain, folks. I mean, you have administrative infrastructure to address, you know, COVID response. But when you're in an independent environment, you're sort of hung out there by yourself. And so I think that was really one of the value propositions. The other piece is that because we take capitated rates, we were able to make some distributions to pre-fund and provide some economic stability to the independent practitioners who, you know, when the faucet of revenue started turning off with the, you know, kind of abrupt stopping of all care in that little interesting window, and Seattle was sort of an early surge, at least, you know, that's what the data was suggesting initially, that we were going to have the surge. And so, you know, that's the approach that we took. So a lot of, you know, canvassing input and determining how we position ourselves to be the best support to the providers that they needed just in time.
And we're definitely going to jump into some of the numbers and not specific numbers, but how financing worked or didn't work. But you know, you mentioned something also about, I mean, you know, the IPA mechanism is about population health, and I know that from spending time in that world myself, you know, there are massive efforts around chronic disease management and care management and focusing on folks that are hospitalized and what happens to them afterwards, and that whole wraparound of you know, just care management and population health in general. I think you had mentioned a little bit about how you were able to go about doing that, but tell us a little bit, Melanie, just real quick about how, were you able to still perform those services for folks, and did that change, and how challenging was that?
Yeah, well, so I think we really, there was a lot of challenges. I think there was some great success stories too around how we could deploy remote patient monitoring and other ways of observing or participating in a patient's plan of care and coordinating that with a physician that was beneficial for alleviating anxiety and ensuring that we could meet a need in the community. I think it's really important to recognize that our fee-for-service healthcare delivery system is based on waiting for care to be needed. Care gets accomplished, a charge is being created. But in the population health space, whether that's full capitated or whatever the case may be, the incentives are built to keep the patient in the right care delivery system. So sort of all of those efforts that we were able to deploy, those are not efforts that I see were widely provided for straight Medicare beneficiaries that aren't otherwise in an ACO. You just sort of care is waiting for it to be achieved somewhere. I think we were able to really recognize the impact that we have in managing population health and how in the time of COVID, that administrative infrastructure, care coordination services, relationships that are built with providers and beneficiaries really provided a backdrop that allowed us to stand up or continue to expand chronic care management in a way that was easier than in the fee-for-service system. So I felt like that was a real advantage. And then because of the financial alignments being in place, I believe that it was a beneficial impact for the providers to have the opportunity to be pre-funded and, keep their doors open while, everyone's trying to figure out how to rebound and what was going to happen. And so, it still remains to be very interesting times as we are trying to find this new normal in both society and in healthcare. But I do think the value-based movement certainly set a lot of the playbook and, all the waivers and things, they were really a page off of the value-based movement playbook.
Absolutely fascinating. Thanks, Melanie, for that. Ray, how about from your perspective? I mean, you're president of one of the largest, most well-known IPAs in the country, and have had a lot of recognition for more than just transactions, but really having stuck with the model and having a lot of experience with the model. And you personally were instrumental in building the capabilities that you have at Monarch today. Tell us a little bit about what this felt like from your perspective, and how you and Monarch handled the sort of entree into this pandemic status, and what that has been like for you all.
Yeah, when I think back to February, March, when things really started to get impacted here in California with the stay-at-home orders from the governor, and what we did as an organization, and again, along with many, many others, first just mobilizing at the IPA administrative level, over 500 employees, and getting, I think, 98% out of the office to a work from home mode, and just the technology deployment that required. And at the same time doing that, trying to really keep abreast of what was happening to our independent contracted physician network. So we literally started making daily calls to offices as to what was going on, what could we do to help them. We had, our network is comprised of a lot of small offices, solo physician practices. And we were tracking on a daily basis whether they were staying open, what their hours were. Many ended up closing physically and just going to telemedicine. Many of them needed our assistance in setting up telemedicine. So we acquired hundreds of additional licenses and deployed those all very rapidly. And then as we looked across the specialty network, the same dynamics, making phone calls, which offices remained open. Some obviously had to close due to positive COVID tests for the providers or the staff, and just really making sure that we had the appropriate access for all of our patients, and where needed, supplement our independent network through our employed model, which was, again, fairly something we'd never done before. Early on, we felt the need to set up a testing site. So we had an urgent care that we converted and built significant capacity, which we ultimately did not need as much as we had built. We were using the parking lot and really had a pretty robust operation in preparation for the surge that we thought was coming that actually didn't in that early 2-month time frame. Similar to what Melanie said, one of the first things we heard was the need for PPE. So through Optum, we were able to obtain significant resources. So we had staff. I mean, it was a joke. We were like a distribution warehouse delivering PPE, masks, gowns to just hundreds of offices throughout the county, and just hugely positive feedback from the doctors that we were able to do that. They were unavailable from the county, unavailable from the normal distribution channels. So that alone, I think, really helped a large number of our offices to take care of the patients that they were seeing. And then similarly, just really began to think through, okay, with all of the elective procedures being scheduled, again, we thought there was a significant surge coming in that March, April timeframe that didn't. It might be happening as we speak now. And really beginning to identify those patients that were getting surgeries canceled that we felt maybe were more than elective, right? And so getting them queued up for when things did open to make sure they were able to get the care that they needed, making sure that they had the ability to get the tests and the follow-up care as appropriate. And then I just think as we thought about it from the specialty standpoint, there really was a bell curve of impact. Certain specialties that are more elective in nature, much more impacted. We are heavily capitated downstream with our physician network, and there was definitely a bell curve of physicians, those who had more Monarch or other managed care business, and as high as 75% of their revenue is prepaid. Really, we're in a much better position to withstand this, keep their staff employed, and be prepared as those patients were coming in, and again, geared up more toward telemedicine. And then on the other end of the spectrum, we have providers that maybe have 15, 20, 25% of their business that's prepaid. And those offices were much more difficult situation, and we're having to go through furloughing their employees, et cetera. So, as we looked at it across the board, we accelerated some payments. We offered some of the larger practices that had a lot of capitated business with us to get cap advances in those early months, all of which was significantly beneficial to helping them keep their doors open during the unknown time and how long this was going to last and what was going on in those early months.
And that's probably the most, we'll talk a little more about the nuances with membership and numbers and such, but the ability to make decisions like that for both of you all to assist from a financial standpoint, the entities the entities and independent physicians and small groups small and large groups, I should say, that are part of your networks, to continue to help them keep their doors open was critical and continues to be critical. And we're seeing that in the fee-for-service world, that is either not possible or people are going without. And it's a very, very different situation. Dawn, I'd love to turn to you for a few moments here and hear from you. Again, you're seeing things on a much more national level. The role of advocacy in all of this. I mean, you've been a huge proponent of all things population health-based. I can't help but recall a time when you and other folks that including the then president at Monarch, were flying back and forth to DC, working with congressional staffers and working on the actual language of the Affordable Care Act. So that's the type, for our audience, that's the type of work that Dawn and APG are involved in. Very strong advocacy group. But anyway, we'd love to get your thoughts on this and what you're seeing from your lens and your seat in the stands.
Well, thank you for that, Karl. So, tried to say this, but we are in such an amazing time, challenging, tragic in so many ways. But for me and APG, an organization that's been, task coordinated, integrated, risk-based care. Excuse me, this is likewise an amazing time because never have we had our sort of business case well proven. Okay, so years past, okay, there's capitated models and, they're better and so forth. And that was known by a kind of a certain intelligentsia, right? And it wasn't necessarily evident broadly to people, right? But, oh my gosh, now look at this picture. Just listen to Melanie and to Ray and what the adaptations they made so rapidly. That could only be done by reason of the payment model, which continued with the cash flow. And then the fact that they're sort of cool and smart CEOs who can say, okay, this weekend we're moving, 80% of our business from face-to-face visits to telehealth. And come Monday morning at 9 a.m., that example is because that's indeed what my membership did. Typically, there's a lot of diversity in terms of how my members do things. So there's IPAs, there's foundation models, and there's employed models, and there's staff models. But here, in sort of one fell swoop, we watched them all move to really high penetration of telehealth, right? High penetration of remote monitoring, stratification to do outreach to those potential COVID patients for population healthy, continued outreach to those that have multiple chronic diseases to keep them healthy. I mean, if ever, it's almost so self-evident now. This is a far superior model. Now, the question will be, is the memory for that, or will we revert to, fee-for-service of old, et cetera, as we move forward? And there's an awful lot of conversation going on about that right now. But in a word, you just really see a superior model. And, I just have to maintain that, ladies and gentlemen of America, this is what we need, proliferated across the country in every nook and cranny. This is the better model. This is what we need. So, exciting times.
Absolutely. And are you? So, what is the regulatory ear like these days for someone in your position and APG in general? Are you having discussions where you're able to say to regulators, hey, let's I know you've got a lot on your plate right now, but take a look at what's happening here, because look at how our providers are doing. Look at Monarch, PSW, and others, and how they're able to continue to provide things like supplies and assist the provider world with continuing to provide care for folks. Are those conversations able to occur at this time, or are they being pushed off, or how does that feel?
No, the answer is yes. They're starting now. There's really a way to read all of the articles and stuff that have been coming down over the last 4 or 5 months. It is fairly amazing to think we're only into this approximately 5 months, but already the rather, highly problematic issues with respect to most notably primary care physicians going out of business. Their cash reserves are drying up, and huge drops in revenue associated with fewer visits and elective surgeries, all of which so that all has been observed. So it spawned this discussion now, particularly in Washington, D.C., about, well, let's do things to make this move from fee-for-service to value-based models, and let's do it in a big way. A good, timely one is that just yesterday, as we talked to some of our colleagues with the Duke Margolis Foundation, there's a collaboration developing between Families USA. Think of this kind of a triad: Families USA, the USAF Care, and then Margolis calling for federal legislation that would ask for more relief funds for physicians across the country, but condition their receipt on those funds on their agreement to move into value-based models like now. And so interesting. You'd have thought we drafted the thing, right? So there are the other voices out there saying, this is the time to rip the Band-Aid off. Let's make this move from fee-for-service to value-based. We all wanted to historically. We all knew it was a better idea then. we now see that quintuply so being the case now. So that conversation is occurring, and we're hopeful that it leads to good things.
Absolutely. We got a question from the audience that I didn't want to pass up. Thanks, Pratika, for your question. For Ray, but I'm going to also ask Melanie, are you guys still assisting providers with PPE and perhaps capitation advances and some of the payment items that you had mentioned? And then are you having to make, I'll just call them hard decisions on who to help and who not to help? Are you guys running into sort of, prioritization issues? Maybe Ray, if you could go first.
Sure. Yes, we continue to deploy the PPE. It's not quite as others are helping as well, and so it's not quite as crisis as it was early on. At the very beginning, we did have to make tough choices on prioritization. Getting it to the physicians who were frontline, in the hospital, our hospitalists, big cardiology practices that were still seeing a lot of face-to-face visits. We tried to urgent care centers that were testing patients. So that's where we initially deployed. Within a couple of weeks, we were able to get enough to really provide supplies to any office who needed it. We did all that at no cost to them. I meant to mention that earlier.
Nice.
And everyone was willing to pay. There was such desperation and need. But again, part of the whole dynamic of the value-based payment model that Don just articulated, we had the resources to get those supplies and deliver them to the offices and just let them know that was just our way of helping them, and there'd be no cost to them. So right now we do continue a little bit, as I say, less urgent. There are more supplies available in the general community than there was back in March, April. But we do plan to continue that as long as we need to. On the payment question, things have moderated. Offices, and again, there's a bell curve, but primary care are back up to 60, 70% of their previous volume. Some specialties as high as 80, 90. Other specialties probably still below 50. I was talking earlier about ophthalmology, GI, those procedures that can definitely be delayed. So we're still being creative in ways. We're helping some of those specialties, but it's a select few versus the broader network.
Gotcha. Melanie, how about from yours and PSW's and the Multicare perspective? How did that work for you all? And are you still going down the path of having to assist the supply chain and such?
Yeah, we are still delivering supply chain. I would actually say that our story parallels Ray's pretty much exactly. We didn't charge providers for the supplies. We wanted to be a resource, and obviously the model encourages us to have that kind of dynamic with our market and the providers in the community. I think that we did pre-funding on some of the incentives that are in place. That I've continued to kind of preload those. But I'd say that people are getting back on their feet. So I would say I almost parallel exactly what Ray mentioned in terms of where we are in the process and how that's changed over time.
Okay, great. Yeah, it's. That's one of the. You would think that would inherently be one of the benefits of being part of an organization such as both of yours and others like you. That
I do think it exposes Karl the vulnerability if you're on your own in this type of situation in terms of how do you even filter information. So I'm sure that Ray had a similar concept, but we stood up a communications portal and a lot of asking and communicating with our providers in the network. But we had a resource that we were taking all of the different information and sort of synthesizing it to what they needed to know, because then you ended up with so much over communication with what to do. And so we were trying to create like sort of a one-stop shop for how would you get your PPE, how would you apply for your loan forgiveness, like all the pieces around CARES Act, what do they need to know, telehealth, what do they need to know. So we set up this sort of communication. We did webinars every 2 weeks where we could talk about the information, but we were keeping information current. So they had one place to go because, as we all know, there's a lot of flooding of information and resources. So it's kind of hard to ascertain what's valuable and what's not. So that was another component of setting it up.
Dawn, you want to? I was kind of chuckling as I was listening to Melanie mention the crazy influx of sources of information. And I know at APG, I mean, you and I have talked about this, and actually we've collaborated as organizations a little bit on this front, but maybe talk to us a little bit about what that's been like for you and what have you had response from your constituents about this? I imagine they came to you for assistance and guidance and all of the craziness that was going on.
Well, they continue to come. So we've got strategic planning meeting coming up here in about a month and a half, and people want to talk. I mean, we know we're in the middle of something big. We don't know how long it's going to last. We don't really quite know what the world's going to look like unprepared. So there's been a high level of nervousness. I think that my sense is, and you can almost hear it, I think, really in a pretty calm, mature tones of Melanie and Ray here, that we're weathering this storm pretty darn well and proud of it, frankly. Health plans are observing that, government's observing that. So, in difficult times, it is indeed the case. Groups come to their trade association, and so we're seeing, frankly, we have not. We were nervous at the APG level that we would lose a lot of members overnight, right? They lose their money and they would stop paying dues. Mm-hmm. We've lost very few by reason of COVID thus far because there's kind of greater value at APG, we would like to think. So anyway, it's a very interesting time where we're sober about where we are, though. So 5 months mm-hmm. into it, we're watching the crystal ball as best we can with respect to vaccine and on, just like everybody else. So we think we're well prepared. We're adaptive, but boy, we've never been this challenged in our whole lives. So,
yeah, for certain. And again, friends and colleagues that I have throughout the industry. For those of you who don't know, I spent time working with Ray at Monarch for a bit, and I was hook, line, and sinker on the model at that point. I had already done some risk work in hospital organizations, hospital systems, and I could kind of sense what folks were trying to do there. But until I really got into the IPA world, I really didn't understand what the capabilities and possibilities were for organizations. So when I left and got into consulting, I thought, oh my gosh, people are going to be lining up for this, right? Well, it's obviously that wasn't the case 8 years ago. So we'll see, but we're definitely seeing how it can be advantageous in many ways to be a part of organizations that, again, focus on population health via a funding mechanism that makes sense because it puts accountability where it needs to be with the power of the pen. Enough of the soapbox there. I'm going to jump into our second poll before we transition, not really transition, but kind of more topics here a little bit. So I'm going to push this poll out. So every crisis provides opportunity to learn how to improve organizations. And obviously this would be one for the books in terms of opportunities to learn. Our question is, do you feel your organization is positioned well to build upon what you are learning from this crisis and the potential value of risk-based models? And it's kind of a loaded question, I suppose, given our topic. But what we're trying to find out is, have folks been thinking about this? Is there visibility to what's occurring in models like this versus the traditional fee-for-service model? So we'll give you all a few seconds here to log in your answers. Are grateful for your participation. Just do a few more seconds here. And we did receive a question that we're going to jump right into about payment parity, because our this whole series of webcasts we're doing at Moss Adams is we're calling it Building Back Better. The idea is to talk with folks and present with folks that are at the forefront of what's occurring in this pandemic and in the ensuing economic crisis, and trying to figure out how we can do a better job as a healthcare system in this country coming out of this. And so the stickiness of these lessons is going to be our next topic. But let me go to this, the results here. And this is exciting to see. 81% roughly of our audience is saying that they are that their organization is poised to learn some things and do things better coming out. And certainly the telehealth story is one that we hear a lot about and talk a lot about and are involved in in a bunch of different ways. Given those of us on the call here, our question is there a movement to ensure payment parity for telehealth services, both fully insured and self-funded? Dawn, I would look to you to respond first, and then certainly Ray and Melanie, if you have any thoughts to add, we'd love to hear them.
So it's a hot issue. It's being debated in Congress right now as we speak. How much should be paid for telehealth services? And there are those that say it ought to be a lower amount since there's lower overhead associated with a telehealth visit, theoretically, right? And then those that say, look, if this is what's saving our nation and our system, why don't we double down and richly reward it? It's every bit as good as in person, and so why don't we double down on it? And there's every, I think, argument in between. I think the comments, you won't surprise some of you to hear me say this, is that this conversation of parity really kind of grows out of a fee-for-service question or framework, right? So in a fee-for-service world, a telehealth visit done, how much you pay for it, very transactional. You know, in a capitated world, Ray and Melanie, they do as many or as few telehealth visits that make sense to them to keep their population and the individuals healthy. And the precise amount they are paid or not paid is included within their cap payment, or will be, at least theoretically going forward as of today, but it will in future quarters and years, I have no doubt. And so I certainly personally like to think that telehealth, remote monitoring, all of this is now being seen as a better really kind of creature of a capitated model, right? You know, feds fraud or overutilization, et cetera, et cetera. In a capitated world, those kind of worries don't exist. So it's a hot issue. I don't know where it's going to end up. Republicans don't really want to pay at full parity. Some Dems do, and we shall see where it turns out. And I think soon we'll get some answers on that.
Fantastic. Yeah, it's watching the. Well, I'll just call it the political storm for now. With all of this occurring in an election year, is it's jaw dropping sometimes, and we're hopeful. You know, you had a really great quote that I'm going to quote you, Dawn, from our discussion earlier this week, is that we need brave, smart policymakers, and we need folks that are going to see through the mud and come up with something that works here, so that the next one of these, or the next phase of this, because it's coming one way or the other. This won't be the last pandemic, unfortunately. So we need to be more prepared to take better care of folks in this country, and hopefully that will come of this in terms of some of the stickiness. You know, Ray, we had talked a little
Karl,
bit.
let me interrupt you. I think.
Oh, please do.
I was just going to interrupt you a little bit. So, you know, there is this question of when we exit the pandemic, are we going to be on these smooth seas of, you know, fair winds and life will be good and easy? Well, I submit they weren't good and easy before the pandemic. I mean, we're in the process of moving kind of from an acute care system to a chronic care system. Why? And that's because 90% of the spend, I think, among seniors, and I think 80% nationally across the nation, of expenditures are made for patients with multiple chronic diseases. We're in a very different sort of patient demand on the healthcare system, and it calls for a different payment method. And so I think the distinction between chronic disease care and pandemic care really is an artificial one, that they very much are the same. And so I think that there are policymakers that agree with me, and hopefully we get some legislation that supports that view. So
that's an absolutely brilliant point, Don. And you're right. We were not smooth sailing by any stretch in our healthcare system. One of the other things that we had spoken about as a group, in preparing for our discussion today, was physician burnout. And, there are no real good answers to that. We know what's happening with the dynamic of young people going into medical school and their expectations coming out of medical school. We know that the transition to a more coordinated care model takes a lot of effort and energy, and we don't have the manpower for the future need if something doesn't give and something doesn't change. But Ray, I'd ask you to share a little bit of the story that you shared with us earlier, because this is something that is a little bit unforeseen, perhaps seen by folks who have been really pushing telemedicine for a long time. But please let me be quiet and let you tell us your story.
Yeah, and I'll touch on the question on payment for telemedicine as well. I think Don did a great job articulating that. And it is interesting how there's such a broad spectrum of opinions on should it be paid more, should it be paid less, should it be paid the same. And as I think about it, and again, Don said it well, in a fee-for-service world, if all that were to happen is we have a different way to see and charge for visits, that ultimately 1 or 2 or 3 years later, when people go back and do the analysis, show that it increased the number of visits because telemedicine is easier and people became more comfortable with it, and it didn't reduce the face-to-face visits to the extent that the telemedicine visits increased, it would be a terrible outcome, right? Because clearly technology needs to become more a part of healthcare, but healthcare does need to become more efficient. It needs to be more affordable. And it kind of ties to the smooth sailing ahead that you referenced, or lack thereof. So although we can't predict exactly how things are going to look when we come out of this, but one of the things we do know is the pressure on healthcare costs, I think, is going to be dramatically greater. So whether we're talking about, all the additional debt we're adding to the deficit, and we still don't see the end in sight on that, multiple trillions of dollars, and just the employer community and the trauma that they've gone through, vast majority of employers, from the impact to their business, and now coming back and facing healthcare cost increases. So I think the delivery system is going to have to figure out a way to have a significant transformation of our cost structure. And I do think telemedicine is going to be an important component of that. How that relates to a Medicare decision on a fee-for-service payment for telemedicine versus a phone call versus a face-to-face, I don't know. But that's where I agree with Don's point. In our model, we don't have to worry about that. If we can take care of a patient with a phone call, great. If we have to send an MA to a patient's house with an iPad and then get that patient, tied into a telemedicine visit with their doc, whatever we have to do to make those visits happen and have productive visits, we need to do. And I hope we don't have to worry about how much I'm getting paid per click on all those different modalities that we're going to do that. The anecdotal story I mentioned, so we, like many others, have a significantly aging primary care physician workforce. Over 30% of our primary care docs are over the age 65. Many of them are contemplating retirement. Many of them were pushed probably a little bit faster toward retirement because of COVID. But there's one physician in particular that he was at an at-risk category. So relatively quickly, he went from in the office to 100% telemedicine. And after 3 or 4 months of that, and he had planned to retire this September, and that was planned before the COVID epidemic. And after 3 or 4 months of being able to practice that way. And he was not a big technology guy. In fact, he was probably, one who grumbled about it. But after 3 or 4 months of having to do that, he actually came back and said, if I can continue to practice mostly telemedicine, I'm willing to extend my retirement indefinitely because I really see the value of this now. And it just opened up a whole different way of practice to me that I never would have thought of as I was being trained, 30 or 40 years ago. So it's one anecdotal story, but I think it does begin to get one thinking about, can we create some additional capacity using telemedicine that we might not have thought through before all this happened?
Well, and if we don't pay attention to those anecdotal stories, Ray, then we're going to lose out on some great ideas. And so I would imagine that physician isn't alone in thinking that if they're experiencing something like this, because there has just been too much pressure on physicians for a long time already in terms of volumes and such. And just to piggyback on the comment about the payment parity, it's we want to promote it, but we all know what's happened with pick a service. Home health is the classic one, right? Over time, what a brilliant idea home health is. Oh my goodness, for so many practical reasons. But when CMS sees the overall cost going skyrocketing like this, whether it's volume or otherwise, they're going to start paying attention to it. And so that obviously results in cuts and such. And so we've seen that happen over and over and over again. And we would want to hopefully learn from that and use this as a situation, use this because of the situation, and continue to have the right folks talking to those regulators who are responsible for setting budgets for things like for Medicare and Medicaid, so that they continue to appreciate the value proposition of something like this going forward, because you'd hate for that to just become a budget item. So greatly appreciate the comments here. Melanie, I wanted to sort of loop you back in on something. You had made a comment about that we manage populations and not people. And while we care for people, the idea here is to continue to refine and develop those processes and services and coordinated efforts. How do you see those perhaps being enhanced? So we already know you guys are poised to do good things because of who you are and the way you're built right now. Maybe talk a little bit about what you see as being different going forward in terms of how you operate as an IPA or as another risk model.
Yes, thanks. So I think of two things around sort of strategy and business model sort of trajectory of what that looks like for us. And I think about the issue of payment parity, and I think about how most systems and the healthcare delivery system at large is built in this very confusing, disjointed way where you make money on certain service lines, you lose money, you have loss leaders, and you have cross-subsidy going on where commercial payers often are supplementing the loss that organizations on a fee-for-service schedule face on a per-click for government payers. Medicaid, for one, in most states, and Medicare in many situations. And so, to me, we have the delivery system side has a high dependence on healthy commercial rates to help supplement that. And I see that with pricing transparency, we're going to see over time more pressure to lower the per cost, per unit fee for service on the commercial space. At the same time, that we're going to have the economic pressure of businesses that I was just talking about, where employers are coming back and they're going to be they can't be faced with higher healthcare costs and many unemployment and the economic, we don't understand yet the full impact of the economic fallout from this COVID. But I'm assuming there's going to be, and I'm projecting as such, that there's going to be more government payered, subsidized Medicaid and so forth. And so we need to be able to be really good as the healthcare systems, and I'm not talking systems as in vertically integrated, I'm just talking about people in population health. And if we did a better job and took more lives into value-based care, then the incentives would be escalating the incentives to be aligned. We could be doing more of the right things with the right intensity. But that is a really hard transition, and I absolutely resonates with me when Ray says the organizations that have 15% of their business in risk are a much different position than those that have 90% at risk. And so I'm in my mind preparing around how do we scale to manage this at a broader level with more government payers so that we can right-size the healthcare system and do it well and make that transition. And I think in population health, and Don speaks about this around his members being, on the tip of the spear for making this work, and this becomes a flywheel and we get faster at it. We bring on more populations and we can make that conversion. But I think that COVID has highlighted the importance of escalating that. It's just seeing how we can manage the rate of change. And it's encouraging to see how much change we have been able to take. So that's a little bit of my philosophy, as well as my window into what I'm thinking is going to occur over time with economic impact.
Yeah, one of the things that we hear folks, we hear about some nerves over what's going on with employment. Unemployment is the right way to characterize it. Transition of populations from the commercial to the Medicaid space, whether it's managed or otherwise, what the downstream effect of all that is going to be. Ray, I remember when I was there with you at Monarch, sitting with you talking about the growth of the Medicaid population, the Medi-Cal population in our membership, and you looking at me saying, well, this is the business that we're in, and if we're going to do this right, we need to be able to survive and thrive in the Medicaid system. We need to be able to have those members and do what we're doing for the other populations for them, and thus set the tone for what we were going to be doing and trying to make that work. This is, I think, a big fear in people's minds is what's happening with the commercial population. Are you all seeing that yet? Are you anticipating that down the road a bit in terms of a migration? I mean, I'm not asking you to predict what's going to happen with unemployment, but surely you must be thinking about this.
For sure. I mean, for those of you who aren't aware, in California, we have 14 million of our roughly 40 million citizens do get their insurance through Medi-Cal, and that number's been growing just naturally over the course since the Affordable Care Act was passed. Over these last 3 or 4 months, we've definitely seen another increase. I think our numbers are about 10% up from where they were at the beginning of the year. And yes, very concerned. Our model, the value-based model, is absolutely the right model for this patient population. I believe that as a taxpayer. I believe that as someone who believes in value-based care. But it is important that the government does figure out, both at the federal and state level, how to appropriately fund that patient population so we can deploy our model in a way that's definitely better for the care of those patients, those individuals. Again, our friends and neighbors. It's 14 million people. It's almost a third of the population in California. So, but with all the political turmoil and the complexity sometimes of really having the folks in Washington understand the value of the model and then how those dollars flow from the feds to the states and in California down to the individual counties is a fairly complex process. There's still work to be done, but I do think value-based care is absolutely part of that solution, but we need to be diligent, and APG is a strong supporter in helping with that, and other organizations. But I don't think that there's still work to be done.
Absolutely. Sorry, I've been trying to manage my mute button here. So we've got 1 minute left, and I could go on for a lot longer with you guys. I'm so grateful for you joining us here today. Any closing thoughts from either of you, Melanie, Ray, or Don, as we look to sort of wind down here?
Don's great at closing thoughts. I'll defer to him.
Well, I'd say we're all learning lessons. Those of us that are in capitation are learning lessons from this. Those that are not are learning lessons. I would urge everyone to learn fast. This is going to be tough in the coming months and quarters, it looks like. To those primary care physicians who are facing insolvency, I think they ought to be joining an APG member, or they ought to start signing risk contracts now, developing the skill sets and the infrastructure necessary to do that. I think health plans on their part should be pushing risk-based contracting downstream. I think the government should be demanding it. I think, we called for smart, brave policymakers. Now is the time for that. So that is, I think, my Christmas wish or something I would tell you, Karl.
Thank you for that wisdom, Don. I think most or all of us are going to share those. And so anyway, I'd love to continue on. Guys, I just want to say how grateful we are. Don, I know you're joining us again in November as part of our webcast series we're doing in lieu of our actual physical in-person conference that we typically host in Vegas. Ray and Melanie, I know you're going to continue to keep doing good things. Charlie probably should have mentioned that you're both board members at APG, and thankfully we'll have your involvement in the ongoing efforts related to the advocacy for this model and for population health and care coordination in general. So again, guys, thanks so very much, and hopefully we can chat again soon.
Great. Thanks for doing this.
Thank you. Bye-bye.
All right. Thank you, Karl. And thank you, Melanie, Don, and Ray, for a great presentation today. If you had questions for our presenters that we did not get a chance to answer, we will do our best to follow up with you after the webcast. If you still have questions, you may reach out to our presenters using their contact information on this slide here. And for more resources, please visit our Moss Adams COVID-19 web pages via the slide deck and handouts widget. Here's a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us today, and we hope you'll join us again next time.